And the COVCARES team is a big, diverse team with researchers across Canada of all levels or stages of their career, senior investigators, mid-career, and young investigators, including trainees. And we have a couple of health system collaborators who supported this study, plus family caregiver collaborators, and even Cheryl Zimmerman, who has done a lot of research and who is based out of North Carolina in the US. All right, Kyle will speak to the next couple of slides related to the study background and methods.
Yeah, so before we get to kind of the results of the study, I'll just give a little bit of a background of the project itself. So our main study aim was to assess the impact of COVID-19 and associated public health measures and restrictions on assisted and supportive living homes in Alberta and British Columbia, and on the family-friendly caregivers of those residents living in the homes. So in order to do this, we did two things. We completed a home level survey with a key administrator in each home, which I can see some of you are on the line right now, as well as a family friend caregiver survey. So the facility survey was completed with me over the phone or self-completed online, whereas the family friend caregiver was mainly completed online, and the survey link was mainly sent out by the homes themselves, which we greatly appreciate your support on. And as you can see at the bottom in red, our first survey captured the first 3 months pre and post March 2020, so wave 1 of the pandemic. And then the follow-up survey we did looked at wave 2, which we considered October 2020 to February 2021. And we approached all publicly subsidized DSL and AL homes in Alberta and British Columbia. We can move to the next slide, Matthias. And why is this important? So why is the work that we are doing on COVCARES important? Well, as we know, COVID-19 has had a devastating impact on older adults living in continuing care settings and on their family-friend caregivers. Safety measures such as visitor restrictions were critical. However, they may have also had some unintended consequences. Most attention has focused on long-term care or on continuing care in general. There haven't really been any studies that have comprehensively focused just on assisted living, which is similar to long-term care, but there are some very key differences. And assisted living homes have struggled too, but many have developed promising practices, and we want to highlight and make these experiences visible as well. There have also been a couple other surveys completed, such as, say, the Health Quality Council of Alberta survey or the Seniors Advocate survey in British Columbia. And while they are valuable, they don't do a few things that our surveys do. And the main one is our survey exclusively and comprehensively focuses on the assisted living sector. Many surveys lump together long-term care, assisted living, independent living, whereas ours is specifically designed to capture the issues related specifically to assisted living. And we are also using items from the Canadian Longitudinal Study on Aging, so we can compare our results to other studies. And an important aspect is that this is independent research, so this will all be published in peer-reviewed outlets. And we can move to the next slide. So our target populations. We looked at publicly subsidized congregate care settings that are more home-like than long-term care homes and that do not provide 24-hour nursing home care, or nursing care. So in Alberta, these are called designated supportive living, and in British Columbia, they are called assisted living. One thing to note is that there is a slight difference between the settings. So here in Alberta, we have DSL 3, 4, and 4D, with 4D being dementia care, whereas in British Columbia, it's all just kind of under the assisted living banner. So in Alberta, you can have different levels of care and supportive living. However, staffing and resources are still very different from long-term care. And assisted living in BC does not have these same sort of levels of care as DSL does in Alberta, especially something like the DSL 4D. On the other side of things is our family friend caregivers. So these are persons who take on generally unpaid caring role, providing emotional, physical, or practical support to a family member, friend, or neighbor in response to a mental and or physical illness, disability, or age-related need. So i.e. caregivers of older adults living in AL or DSL homes. And the one final criteria we had was that they must be a caregiver of a resident that lived in the AL home for 3 months or more prior to March 1st. And that was just because this was the kind of main time frame of the study. And this slide just kind of gives an overview of our study sample size. So you can see in wave 1, 64 homes in Alberta participated and 40 in BC for a total of 104 homes. Similarly, we had 673 caregivers altogether participate in the study, and we had quite more in Alberta than BC for caregiver surveys.
All right, that's initial summary of the caregiver findings, and I will pass it over to Colleen for a couple of slides.
Thanks, Matthias. So I wanted to go over some of the core components that we asked in our caregiver survey. So we touched on their sociodemographic characteristics, so their age, their gender, marital status, their relationship to the resident, the education and their employment, income, and also changes in employment and income because of COVID. So looking at whether they had a reduction in income and how concerned they were, for example. Broadly, their ethnicity and primary language. We looked at a number of items that captured their engagement with the home, and we asked these items both in terms of their involvement 3 months prior to March 1st, so using March 1st as the emergence of the pandemic, and then 3 months post. So we looked at items on how much help and oversight they provided and how often in those 3 months pre and post, touching on instrumental activities of daily living, basic activities of daily living, but also psychosocial and spiritual. Their visits and change in visits, whether they were in person or by telephone, mail, email, or virtual. Their awareness and knowledge of whether the resident had access to health, mental, and social care if needed, pre and post, and whether they considered moving the resident out of the home, and if they did, what their experiences were. We asked items about the level and nature of communication with and between the home and the caregivers regarding infection prevention control policies, visitor policies, COVID outbreak status, and testing status, both with residents and staff. And we asked about the caregiver themselves, about their health and well-being. So the caregiver's self-rated health, their number of chronic conditions, their own COVID testing, their mental health. So we asked about their depressive symptoms and anxiety symptoms, whether they had social support available, and any coping strategies they were using. And last, which I wanted to focus on today in presenting some findings, was the caregiver's concern about residents' health and well-being, both before the emergence of the pandemic, so 3 months pre and 3 months post March 1st. So looking at how concerned were they before and after, and we assessed sort of the change in the level of concern about residents' health and well-being in various domains. Next slide. So for that item, in asking about the caregiver's concern pre and post, the wording of that exact item was, in the 3 months before March 1st, how concerned were you, if at all, with the health and well-being of your family member or friend in the following 9 areas? So we asked about their concern about residents' activities of daily living, their mobility, their cognition, their depressed mood, their loneliness, anxiety, their food and fluid intake, presence of pressure ulcers, and frequency of falling. So that we asked the caregiver to give the assessment on those activities for the resident and concerns pre and post. Next slide, Matthias. So our caregiver sample, just to give you an idea of who responded. So as Kyle mentioned, we had 673 complete responses. Most 3/4 were women, as you might imagine, and many of them are daughters. Predominantly white respondents, and most were married or had a significant partner. In terms of their age distribution, they were largely middle to older aged. So 55 to 64, 65 and over. We had a nice distribution for education for our caregivers. So a nice distribution across education and also income. What's interesting, about 27% of respondents noted that they had a reduction in their income due to COVID, and most of them were quite concerned about this reduction. So it's another element of understanding what caregivers were going through at the time of the pandemic. Next slide. In terms of distribution of caregivers by zone, we did actually have caregiver respondents from all 5 of the zones in Alberta and 4 of the 5 health regions in BC. But you can see that most of them came from largely urban centers and from they were affiliated with larger facilities. So about 2/3 affiliated with larger versus small, and with urban versus rural homes. But we did have a nice mix for profit and not-for-profit status, so about half of both of those. Next slide. So in terms of some key findings, we created this slide to show you what I'm going to present, and then also what Matthias is going to present. So I mentioned already this key question we asked caregivers. What was your level of concern 3 months before and after the emergence of the pandemic about residents' change in their ADL, their mobility, cognition, in their mental health, whether it's depression, loneliness, anxiety, and then other items like food and fluid, pressure ulcers, and frequency of falling. So Matthias is going to talk about what were the general characteristics of caregivers, items from the home that we collected, or disruptions in services and therapies for the resident. How did those factors impact on a change in caregivers' concern? So he's going to present that first. And then I'm going to talk about how a change in caregivers' concern about resident status in these 9 areas affected their own health and well-being. So how did an increase in concern about the residents pre and post the emergence of COVID affect the caregiver's own level of depression? We also looked at their anxiety and health status, but I'm only going to focus on depression for today. Go ahead, Matthias.
So I need to unmute myself, that helps. I will focus on the first set of analysis we did, specifically which factors are associated with how concerned caregivers are about certain resident issues. So as Colleen presented already, we asked caregivers about how concerned they were related to residents' loneliness, depressed mood, cognition, anxiety, mobility, falls, ADL, food intake, and pressure ulcers. And the blue bars are the percentage of caregivers who were moderately or severely concerned pre-pandemic. And the orange bars are reflecting those who were moderately to severely concerned in the first 3 months after the outbreak. And you can see that for all of them, it went up drastically. But especially the mental health issues, loneliness, depressed mood, and anxiety on the level of residents was something that really concerned the family caregivers. So these are the 3 outcomes that I have focused on primarily to start with in my initial analysis, but there is definitely more to come and we will explore our data in much more detail. So interestingly, we also asked family caregivers about their perception whether certain services were available, if the resident could access services if needed. And if family caregivers thought that counseling services were not available, that drastically doubled or almost tripled their risk of being concerned related to the resident's depression or loneliness, respectively. So perceived access to services really is something that is A, modifiable, and B, severely affects family caregivers' concern about the resident situation. Same for residents who did not have access to, or for which residents that the family member thought did not have access to physical therapy or occupational therapy. That was specifically relevant for their concern about the resident's anxiety, knowing that especially the occupational and recreational therapists in these facilities played quite a big role, meaningfully helping the resident to be occupied and also developing quite some intimate relationships to these residents. So having access to these therapists seems to be a crucial component as well. The next outcome is quite interesting too. We had an item asking family caregivers whether there was an outbreak, yes or no, and if there was one, did they feel like they were properly informed about what was going on, yes or no? And our reference category here was there was no outbreak. So in facilities in which there was an outbreak, but family caregivers felt they were properly informed, the risk of being concerned about the residents' mental health issues was not different from facilities where there was no outbreak. But if there was an outbreak and family caregivers didn't feel informed properly, that doubled or tripled almost the concerns about resident mental health issues. And that's another factor that's really modifiable. To what extent do we properly inform family caregivers? And it's not so much relevant if we think they're properly informed, it's their perception if they feel there is transparency and consistent communication. Females were more concerned than males. And if the participant reported higher levels of social support, that reduced slightly their level of concern. So having social supports, which is of course self-explanatory, helps you mitigate some of the concerns you may have. All right, and Colleen did some more detailed analysis using the items that I just reported on, plus other factors and depression. So back to you, Colleen.
Yeah, okay, so next slide, Matthias. Just to talk about, we looked at a couple of, before I show the relationship between the change in the caregiver's concern and the caregiver's level of depression. I wanted to also emphasize that we did ask about engagement aspects of caregivers' involvement during the 3 months after March 1st. So one item we asked was, do you feel that the home or staff created or facilitated opportunities for you to be well informed or involved in the care and well-being of your family member or friend? And you can see that 3/4 responded yes to this item, which is reassuring. However, on the flip side, 1/4 responded no. We also asked the item about whether they considered moving their family member or friend out of the home because of worries about the impact of COVID. And about 1/5 said they did consider, but actually very few did go forward and move their family member or friend. So just out of that 20%, which was 139 respondents, only 17 or 12% actually did move them primarily back to their own home. And the barriers for not doing something about that were primarily not feeling like they could cope at home. So I don't want to spend too much time on this. I created some variables looking at the change in caregivers' level of concern pre and post for all 9 areas about residents functioning, from their ADL to their mental health to falls. So I don't want to go through all of these, but basically I looked at whether they remained not concerned, they remained only slightly concerned, whether they increased their level of concern. That increase could go just slightly higher or moderately higher or extremely higher. I'll show you some of those findings with the caregiver's depression in the next slide. But some key points to note is that for most of the physical, so the residents' physical well-being, so their ADL, their mobility, their cognition, food and fluid intake, and falls, just over 1/3 or more of caregivers reported having increased concern about all of those areas. And you can see that for the mental health status of the resident, it was much higher. So about 50% or more caregivers reported an increased level of concern about residents' depression, loneliness, or anxiety, comparing their 3 months pre and post. Next slide, Matthias. So as I mentioned, I looked at how that change in caregivers' concern then impacted the caregiver's level of depression. So just to let you know, overall, the prevalence of depressive symptoms in our caregiver sample was just about 39%. So this is considerably higher than what we might see sort of in a non-COVID kind of community-based, similarly aged sample. So we can see sort of the level of mental health concern among caregivers themselves. In terms of caregiver anxiety, it was roughly about 29% of caregivers showing meaningful anxiety. And about 29% of caregivers also reported their health status as being worse at the time of the survey compared to 3 months prior to the COVID outbreak. So the graph I'm showing here, so each blue bar is showing for each of those levels of a change in the caregiver concern, what was the level of caregiver depression. And so I've just shown right now the change in caregiver concern about residents' ADL status. But if I showed this for residents' mobility or residents' cognition or their mental health, we would get similar findings. So what we see is sort of a nice kind of dose response. So the lowest prevalence of depression among caregivers was for those caregivers who remain not concerned pre and post pandemic about residents' ADL. And the highest level of depression among caregivers, upwards to 50% or greater of caregivers being depressed, was observed among caregivers who had an increase in their level of concern about the resident. So we're seeing how caregivers' increase in concern about various areas of health and well-being about residents then impacted their own health and well-being in terms of their level of depression. And we see this sort of doubling of the risk of depression in caregivers as their level of concern increased, even once we control for confounders. And what I mean by that is once we control for other characteristics we know are related to depression. So for example, caregivers' age or gender, or the item I mentioned before, they had a drop in their income and they were concerned about it. And all of those items are also important correlates of depression. And even once we adjust for those, we see that this change in caregiver concern remained the most important predictor of caregiver depression around the time of just shortly after the 3 months post the pandemic. Next slide, Matthias. Oh, sorry.
Do you want to talk about these additional things, Colleen?
Yeah, sorry, I missed that. Sorry, I was zoned out for a minute. Sorry, I also wanted to mention that we then also looked at coping responses that caregivers reported shortly after the onset of the pandemic. So we asked them, because of the stresses and strains, did you seek counseling? Did you start an over-the-counter drug for sleep? Did you start a prescription drug for depression or anxiety? Did you start or increase your level of alcohol use? Did you start or increase your level of smoking? And did you start or increase your level of cannabis use? And on the right-hand side, the first estimate is just the overall prevalence of all of those coping responses. So 7.4% of all of our caregivers reported seeking counseling. 9.4 reported starting an OTC drug for sleep, et cetera. But in brackets are the estimates for caregivers who reported, who were indicated as having meaningful depressive symptoms. And you can see for all of them, all of these coping responses were much higher in caregivers who were depressed, with the exception of the smoking. So for example, starting an over-the-counter drug for sleep, roughly 1/5 of caregivers who were depressed started an over-the-counter drug for sleep. Go ahead, Matthias.
All right. I will talk a little bit about some of the findings that we collected in our home level survey. This is just an overview of what we actually included in that home level survey. Of course, we started with some facility characteristics such as size, ownership, location, staffing questions. We were also asking which model of medical care these facilities were applying. Like, do you have a roster of physicians, or do residents select physicians themselves? Do you have NPs? We were asking about outbreaks experienced, challenges ensuring PPE for staff, residents, and related mitigation strategies. We were asking about challenges ensuring adequate education, training, and communication for care staff, residents, and families. We also asked facilities for perceived factors that help them prevent or limit the spread of COVID-19. We asked them what additional supports they would have wished for, how prepared they felt, what changes in admission and transfer criteria there might have been from their perspective, what measures did they implement that most importantly, of course, referred to all the public health measures, physical distancing, and protective measures, factors impacting the quality of care and life of residents from the perspective of facilities, the impact on staff morale, measures to mitigate measures to mitigate the impact on residents, and to what extent were families and friends included from the perspective of the facilities. So Colleen just presented that's almost 75% of the families thought the facilities provided them with meaningful ways to still engage, be involved, and be informed. That's quite interesting because the facilities overall, I think it was 95 or 97% of all the facilities thought they provided meaningful information and opportunities for engagement. So while the perception among the family members was quite high, it's still quite the discrepancy between the perception of what the facilities reported and what the families reported. This is an overview of the facility sample. In total, we included 104 facilities. Our homes, 64 in Alberta, 40 in British Columbia, and this is how they were distributed across the different health regions. So most participated in Alberta Central and Edmonton, and in BC, most participated in Fraser and Interior, and we had facilities or homes in each of the different regions. However, some of them were only sparsely represented here. We had a nice distribution between urban and rural homes, 43 versus 57 homes. Also a nice distribution between not-for-profit and for-profit homes, and a broad range of different sizes. On average, they had 54 point something beds, and the median was 48.5. We split facilities, our homes, up by the median number of beds within each region, and we managed indeed to have half of the homes to be in the small category and half in the large category. Now, this is just a quick overview. I'm not going to go through all that in very much detail, but this is just an overview of some of the challenges that homes reported. Almost 10% of the homes reported staffing challenges, especially for care aides and LPNs, even before the outbreak in the 3 months prior to the pandemic. But these staffing challenges, and that's nothing that's new to you on the call, all of you experienced that and dealt with that, but it's just confirmed in what the homes reported to us. The staffing challenges drastically increased, especially in the first 3 months after the outbreak, due to several issues that we are all aware of. What you see here is the proportion of homes that reported moderate or severe shortages in certain PPEs. Hand sanitizer was short at the beginning, the masks, alcohol, wipes, and so on. So that all reflects what we already heard. And that hasn't been emphasized too much here. We also asked the homes if they had challenges talking or communicating things related to infection prevention and control to care staff, families, and residents, as well as communicating testing, the need for testing and testing results to care staff, families, and residents. And you can see that between 40 and 50%, or between 35 and 50% of the homes reported challenges with either of these, and most of them reported several of these challenges. So communicating things properly was something that they sometimes were challenged with, especially because sometimes they didn't know themselves very well what direction to take and how to operationalize the public health measures, but other reasons as well. Here is an overview of some of the measures implemented. Physical distancing measures, the one that most commonly was implemented early on was cancellation of the group activities. Many homes canceled clients dining together and had them dine in their rooms, or asked to stay in their rooms altogether, or maybe dining in shifts. And that's quite interesting, because when you ask facilities who thought which of these impacted residents most, basically, the highest proportion of facilities or homes said that cancellation of group activities was quite an impact on residents. And this was exactly what happened at the beginning. Most facilities did that, but that's something that impacted residents most, and all the others, of course, as well. Interestingly, only 20% of the homes reported they felt poorly or not at all prepared for the pandemic, but over half reported a decline in staff morale. And here are a couple of quotes, because at the end of the survey, we gave the participants the opportunity to give open text responses to emphasize and give us more context related to their overall experience. So the red bubbles here are Alberta homes, and the blue ones are BC homes. And it's quite interesting that if you do that in a survey, many participants usually skip that opportunity or give very short responses. Over 75% of our homes quite comprehensively responded to that open text field. And not short answers, but really like comprehensive responses. So for example, this one here, I think it has been extremely challenging for operators, the go-to between AHS and the resident family staff. Difficult when you get something in place and then AHS would change their policies and you would have to go back and change it, give an update, and then AHS changes it again. Operators took a lot of blame for things, turned into policing, very tough, created a bit of distrust and resentment. Mind you, that is a statement of the very early stages, as much of that was mitigated later on, but it was obviously a very stressful situation at the beginning. In BC, one participant highlighted the mental health we have been worried about. I think they're referring to the resident. Re-implemented things with all the protocols in place. Hard for everyone who works here to witness the mental health issues with people and the sadness. Residents stating that our restrictions are too tough after the initial period. That sort of thing is really hard. Not being able to hug is also a big deal. Or this one here, at first, just wanted to keep everyone in the bubble and keep them safe. But when we started letting residents out again, it felt like sending your kids off to school, had to learn to balance. We need to keep them safe, but they also need for their mental health to be connecting, getting a better balance of it now. when healthcare aides would phone public health or 811, not consistent communication on whether to come back to work, criteria for it, very little concrete information. So lots of uncertainty apparently going on. And the participants, like the facility care staff and managers, also, it was hard on them to see all the mental health issues that the residents had. One BC home, again, I think it's overall very frustrating for all staff, family, and residents. Tough keeping up with the latest protocols and enforcing that. Confusing for the residents when the protocols are changing. If they're out in the community not wearing a mask and seen by another resident in our home, get called out for it. So it also caused conflicts among residents, and that had to be mitigated by the homes again. And I have two more here. This one is emphasizing that assisted living indeed is different from long-term care, and not always taking that into account was hard on the homes too. Being assisted living where we are not fully supported by external services, really left at our own devices to find and seek out services for residents. In terms of residents moving in who don't have doctors, assisted living has to do that. If we have families dropping off essential things for the residents, we have to do that. Doing all the little things, fixing cable TVs, fixing telephones, etc., keeping residents engaged in the building. There are gaps within the system being able to support residents without them losing any type of care. Now delivering meals into suites, making sure residents are okay. Need more hands on deck. Every assisted living site is doing something different too, no uniform way to do it. That was again a home in BC. And that is my final quote here. That's a home in Alberta. The designated visitor was a bit of a game changer for us. Solved a lot of our issues. Someone who can fix TVs, etc. Seems like TVs are an issue in Alberta too. Glad Alberta stuck with that. One of the things we noticed we struggled with because we don't have a rec coordinator for DSL3, no funding, don't have that rec coordinator to help with things. Limited staffing with DSL, so people don't have time to run something for 80 residents. It's hard for when AHS lumps together the orders for DSL and long-term care. All right, Colleen will do the conclusions and next steps, and then there will be a chance for comments and the discussion.
Sure. So you can press again, Matthias. So just in some of the findings we've presented today and realizing, and you're getting a sense of how much data we have, I just wanted to speak to some of what I showed. So talking about sort of the overall impact of COVID and then the related restrictions, public health restrictions. Certainly all of this led to an increased concern among caregivers about residents' health and well-being, especially about their mental well-being. And that this increased concern then had an impact on the caregivers themselves in terms of their level of depression. And that for some folks with depression, caregivers with depression, this does seem to perhaps have led to some potentially negative coping strategies. So emphasizing the need for increased awareness of mental health issues, need for support and care among caregivers, which we acknowledge existed prior to the pandemic, but has been exacerbated following the onset of or the emergence of the pandemic. Communicating and informing caregivers and ensuring resident access to services was shown with Matthias' work to alleviate caregivers' concern. We found in our data that many homes, according to caregivers and the informants from the homes, did all they could to engage caregivers, but they themselves face considerable barriers. So inconsistent communication, poor support from public health, surrounding services. So this sort of feeling isolated on an island. And since I'm in Ontario, I'm well aware of what happened with long-term care. And it's interesting talking to some long-term care sites in Ontario, because even when public health or acute care or the army got involved to assist some of these homes, the long-term care homes that had sites that were considered more assisted living or retirement homes didn't even think to acknowledge that they also needed assistance or help. So it was even these multi-level campuses of care sort of realized later that their own retirement or assisted living sites were neglected with this early support. And we all know that the focus was on acute care during the stresses and strains, and less so on surrounding community-based care. So we hope that as we continue to evolve our analyses, that this will enrich continuing care reforms that are happening nationally. So much of that, the working groups that have been formed are talking only about long-term care. And they're not talking about DSL or assisted living or retirement homes, or thinking how they vary across the country and how much their own unique experiences and barriers could have been far worse than what some of the long-term care homes faced. Not that the long-term care homes had it easy by any means. Next slide, Matthias. So our next steps, we're going to continue our analyses and look at our follow-up data, which is great that we have follow-up data to look at change for caregivers in the homes as we went into the second wave. We're going to look at the relationship of home characteristics as well. So I can tell you for now, in looking at the results I presented today on caregiver depression, we did look at, whether it was for-profit or not for-profit, size, urban, rural. None of those home characteristics were related to the level of caregiver depression. So far, we're not seeing home characteristics as being salient, at least for those core characteristics. We want to continue our presentations, and we're interested in hearing your comments and questions, because then we can go back and tweak things and run analyses to answer your questions. Eventually, we want to link our data, so our caregiver survey data and our home survey data, with population-based data for residents themselves. So to be able to do that, we've submitted a few more grants to hopefully get funding to allow us to do that, because obviously a big piece that we don't have is in this whole look at assisted living and DSL is what happened to the residents. Go ahead, Matthias. So we'll just end, and we can go into some Q&A. So just again to emphasize a big thank you to our homes, our informants and caregivers, our partners and knowledge users, and to our funder. And so Matthias, we can open it up to questions now. Thank you everyone for
Absolutely. Yes.
Did you want to monitor them in the chat, Matthias, or just have?
Yeah, I've got the chat open here, but you also may as well just raise your hands or unmute and ask a question. Hi, Steve. I see your hand. Go for it.
Hey, thanks. Thank you guys both. This is a fantastic presentation. I think it's really thought-provoking. I know this is one of the things we're really trying to work on, is how we build those relationships between the family members and our caregiving teams, who that's quite critical in terms of the outcomes of both the residents and I think our long-term ability to maintain care with burnout risk and resiliency for our own care teams. But quick question for you, because I was trying to wrap my head a little bit around the linkage between the depression, so the negative impacts on health of the caregivers, and some of the feedback on the home. So is that 38 or 40% of folks who are rating high in terms of depression, is it that those are the folks who maybe are rating their experiences regardless if it's care or not, or is it the depression that really is driving the feedback, or is it the feedback that's related to the depression? I guess I'm just curious if you've gone back and forth with that, and I suspect you probably have. So I'm just curious on those conversations, if you could share what your guys' thoughts are on that relationship.
Do you want me to go ahead, Matthias?
Yeah, you probably have looked at that more carefully than I did, focusing on the depression variables. Yeah,
Steve, if I'm understanding you correctly, and correct me if I'm wrong, you're wondering, so we've got sort of an understanding of caregivers' depression and how their change in their level of concern about the resident sort of was associated with their depression. So yes, do acknowledge that although we had timing embedded in our questions, like pre-post, 3 months pre-post, and then the assessment of depression of the caregiver was at the time of the survey, which is later. We acknowledge that it's still cross-sectional, right? So you are right in that someone who is showing depressive symptoms might have had a more negative sort of perception pre and post. So they might have had an increased level of concern as well, if that's what you're getting at. To try. Yeah, okay, great. That's what I thought. So to try and get at that, when I modeled this, I tried to account for other aspects of their perception. So their change in health and some of the health domains as well. We don't have a truly baseline measure. That's the problem. So we don't have what was their level of depression prior to the pandemic. So we do have this issue of interpretation to some degree, but we tried to account for other variables that might pick that up as best we can. we might be able to look at some of that with our follow-up data. I think what's interesting is that the other variables that sort of had time embedded as well, like did you have a change, a drop in your income, and were you concerned about it post March 1st? Yeah. That was also a strong predictor of depressive symptoms in caregivers. So the timing around the question does seem to be picking up something. We're assuming the directionality of the association, but I completely agree with your point. Thank you.
This is great. And I think probably what it flags is some important conversations that we as owner operators can have with some of those caregiver supports as a bit more of a public health, because we're quite dependent on the resiliency of our caregiver teams, yes. Both informal and formal. So I think this is very important to those conversations. Yeah.
And to some degree, even if we can't be sure of the direction 100%, in a way, it doesn't matter. These things cluster together, which means, even pre-pandemic, concerns from caregivers and the impact on their own, mental health and what that means for their own health and engagement and all of that. These are all important things that cluster together. And so they do need attention. So thinking about, the fact that the caregiver might need their support as well, even despite a public health crisis, which I'm sure it's something that's considered, but maybe needs to be approached really differently.
And I think it is partly supported by the open text responses in the family survey as well. That's what the caregivers tell us there too. We haven't systematically analyzed them yet and linked them again back to the quantitative data. But like for the facilities, we have a very rich source of open text responses, and we were pretty sure that they will be able to contextualize some of the quantitative findings we see in a bit more detail.
Brilliant. Thanks, guys.
Right, I see Caitlin Edwards has posted a comment. Really informative study. It is great to see how much families value planned activities and how the cancellation of some of these things impacted the family's level of concern for the resident as it relates to their mental health. Fully agree. So especially the power of being informed is something that I didn't expect to show up that clearly. It's clear that if you're informed, you're doing better. But I was expecting that if there is an outbreak, people would be concerned no matter what. But apparently being informed really leads family members to trust the facilities, that they can handle it and that they manage it. And that really mitigates the concerns. And I also agree with the structured activities and the access to essential services. That is something that we should really try to keep up no matter what. If any other outbreaks or waves should come up, it shows that this deeply impacts not only the concern, but then in turn mental health issues.
Everyone's so quiet. Can't pick on you because we can't see you. I wonder with some of the items, we collected, if you have your own question that you would like to see analyzed. So if you have a particular question, we have the data for and you would like to see some analyses done. Is there anyone?
So Laura posted a comment here as well. Good feedback on the importance of communication with families, true in any crisis, pandemic or fire. Tough part is how we can better prepare for this in times of crisis when resources are so stretched. Absolutely, yeah. This is especially in the early stages of the pandemic. Nobody knew really how to deal with that. And I think things have improved. Hopefully that's what we're going to see in our data as well, that during the later stages, things have evened out a little bit. But you're right. I mean, the resource limitations still are to a large extent prevalent and limit what you can do. So yeah, if people have certain questions that they're really interested in, as you just said, Colleen, if you want us to focus on certain aspects, feel free to reach out to us and let us know. We're more than happy to cater our analysis to some of your needs if the data allows it. All right, we will make the recording available on our website, and we will let you know once it's uploaded, so you can listen in again and think about it a bit further. And if you have any other questions or comments that come to mind after the fact or after the presentation here, just reach out to Colleen or I, and we'll be more than happy to get in touch with you.
And again, thank you everyone for your support and participation. It's been a challenging time for you all, and we know that and appreciate it. So thank you very much, and thank you for attending today.
Yes, thank you very much, and have a great weekend, everybody. Not quite yet, but we're getting close. Take good care.
Thank you, everyone. Bye-bye.